All right, back in Santa Monica with the doc. I'm so excited because it's been a few months since
Seems like
I've been here. Yeah.
Yeah.
Too long, So good to see you, Doc.
Good to see you too, Dave.
So listen, I want to start this new segment, by reminding people that a few months ago, I want to say anywhere between 6 to 9 months ago, you had talked about a book you were working on, and you told me it was supposed to be out around that time. So of course, first thing out of my mouth today was like, "Where's the book?" And the book is not yet released. And tell us why, what's going on.
Well, yeah, the main reason is because we're trying to release it at the proper time, I guess, is what I'm being told.
Right.
I also, to be quite honest, and I don't think so, this was the reason for the holdup, but I wasn't really happy with the initial first product.
Well, that's important.
I don't know if people realize, I didn't know how books were made, but being a nerd and speaking in nerd speak wasn't working very well. And so from the get-go, though, I had somebody very, very accomplished, a fellow named Bruce Wexler, helping to take my nerd speak and convert it into something that's more understandable.
Layman?
Yeah. I mean, what I think is fantastic and really cool. A lot of people may not agree with. A lot of people don't agree with. So anyway, Bruce was instrumental in translating it, and of course, I think the words they use in the industry are a lot of babies were killed, meaning a lot of these little pet projects of mine that I thought people needed to know about were, no one wants to hear about that, or that's too complicated. So,
okay.
When I saw the first version anyway, I was kind of disappointed. I thought, okay, well, it doesn't flow and it doesn't really convert well and tell people what I wanted to tell them as much as I wanted to. So anyway, we went back to the drawing board and did some more work. I'm very happy with what we came up with now. And as a matter of fact, final edits were due on June 1st, and so
great.
We plan on releasing it at the end of January, but who knows if that'll change or not. But I'm really excited about it because the book is, it's entitled Cheating Death, but it's to grab your attention, obviously.
Yeah, I like it.
But it's about regenerative medicine and what we can do with it now, which, when I was growing up, I'm in my 60th year. I mean, and I tell the story in part in my book, like when I first injured my neck, we didn't have any alternatives except fusion in your spine or what amounted to a fancy door hinge. And I was like, okay, I'm not doing that. And and because of some other things, I just never looked into what could be done. And in hindsight, missed out on a lot of opportunity to do things that might have resulted in better outcomes today. And so I don't want people to do what I did and miss out on some of these opportunities. We have so many more opportunities with regenerative medicine to not only fix breaks, literally and figuratively, not necessarily a broken bone, but things that have started to go south because of age or because of not taking care of ourselves as well as we could, but to prevent these things from happening. What we're now referring to as a disease, old age, aging, rather than a process that we can at least avoid to a large degree. So anyway, I know it was a simple comment, but I'm excited about it, and certainly when it finally gets released, I'll make a mention of it here so that if anyone's interested, they can grab a copy.
Yeah, I want to make sure to let people know because there might be a way for them to actually pre-order before it comes out. You'll have like a place.
That's all beyond my knowledge and scope.
But we'll let people know.
Yeah, no, absolutely. I appreciate it. Sure. I mean, I thank you.
Also, one of the things we've been discussing at lunch when we see each other before we film is that you were talking about possibly opening a new clinics, possibly in Texas, possibly in Florida. So today you just told me that you actually opened a new center in Texas. Talk about it for a second because that's really interesting for people living there.
We're excited about it because, really two reasons. One, there are things that we can't do with telemedicine that we have to do in the office. For example, I believe if we're not there yet, we're really close to being able to use testosterone pellets effectively. The problem in the past was they didn't release the testosterone in a consistent manner, so we'd get really high spikes, and then the patient would be a month with really low testosterone levels complaining, well, what do you mean I have to wait another month before I can do my pellets again?
Right.
We believe that our compounding pharmacy, Empower Pharmacy out of Houston, Texas, by the way, has found the solution. And our other practitioner in Houston, who's been working with us now for over a year, Dr. Todd is a former fellow with, actually technically I guess he wasn't a fellow, but he used to work with Dr. Lipschultz, who I've mentioned many times before out of Baylor, who's one of the leaders in this field. Anyway, been trained in using pellets. So we have to have an office for that. We have one in Woodlands, the Woodlands they call it in Houston. And we plan on opening more of these clinics for the second reason, which is we're still hopeful that the FDA is going to approve stem cell use in this country sooner rather than later. We're halfway through our IND application trials, the IRB we filed for post-concussion syndrome, and so those results should be in probably by no later than the end of the year. And anyway, the way things progress, we're hoping that sooner rather than later, the FDA is going to sign off on that treatment. We also have other avenues now, I think through the era of the Trump administration, that allow us to, they call it compassionate use, and there's another term they use, but and now might allow us to start using stem cells even earlier. And I say stem cells, whether they're autologous, meaning we harvest them from your own body, or we get them from umbilical cord tissue, for example, which would be allogenic. And then in that case, we're really not using them for the stem cells so much as for what comes with them. Mm-hmm. But I know we're going way off into the weeds. I was just trying to answer
that's okay.
A simple question. But yeah, we have a few reasons for opening up other physical locations so that we can do more stuff.
Well, that's good news for people in Texas, because people ask me all the time, oh man, I wish I was in Santa Monica. I wish so you're branching out a little bit, which is great. So I wanted to let people know who's watching this that to contact that clinic, it's still all the same information. So whatever information you see at the beginning of this video, so the phone number, the website, all that stuff is still accurate. And they'll just redirect you towards the closest
Glad
center.
You said that, because that might get confusing. Yeah. Our number to get to any of our clinics is still the main number. So for anyone interested.
And all those informations are at the beginning of the videos. So if you want to get a Skype consultation or call the office or fax, or all that stuff is there. So congratulations.
Thanks for the advertisement.
Yeah, congratulations, Doc.
Thank you.
All right.
So am I going to read the questions today?
You are.
All right. Let's see. The first one I have is from a young lady. Young lady. I'm a 47-year-old female with no energy, starting to gain fat around my waist no matter what I do. I am very athletic and have been my whole life, and I'm being told by all my friends and my husband that I should be checking my hormones. I've heard that hormones increase your risk for a stroke and cancer, so I'm confused about what to do. What is the truth, please? Great question. So, as I've said before, I'm sure, and what is unfortunately not common knowledge is that men and women have the same hormones, just different ratios. And testosterone, for example, does the same thing in women as in men, meaning provides energy, or I should say supports energy, right? Because without it, you can be less than energetic, but it might not be the only reason that you don't have energy if you're not getting enough sleep, for example, and other obvious reasons. But anyway, testosterone can help with libido, sense of well-being, body composition, and typically someone of this age who's been athletic waves the white flag somewhere later like this, rather than when, by definition, perimenopause occurs somewhere around age 35. And I say perimenopause, that's when the hormones start to go south on us, and we lose the leverage of testosterone to support the body composition we're looking for, which is typically holding muscle and losing fat. So that first and foremost has to get out there. And then unfortunately, the Women's Health Initiative, which was a remarkable study, it's about 161,000 females, I believe, and they gathered a lot of information which has changed the way we practice, mainly in a good way, but unfortunately in one bad area, or in one bad way, because most of the estrogen used in the study was Premarin. It's not a bioidentical hormone, is one thing that's very important. And the other part is Premarin is 50%, I think it's 50, maybe 45%, equilin, which is derived from horses. It's a horse hormone. And we get it from, like the name implies, pregnant mare urine, Premarin. And equilin is 1,000 times more potent, for example, in the human uterus than it is horses. And you can see how we might have problems with the side effects of excess estrogen being, it's a marginal increase, but it's statistically significant in stroke and cancers. Now with cancers, there's a little caveat there that really when it's combined with progesterone actually increases the risk of breast cancer. But I don't go too far into the weeds. The bottom line is equilin is so much more potent, as is estrone, another human estrogen, 16-hydroxyestrone, that we already know causes an increased risk of cancer. So we actually have a test, and again, I apologize for going a little too far into the weeds here, but a 2,16-alpha-hydroxyestrone test, which gives us a ratio of something we consider beneficial or safe versus something that we know can be detrimental and is unsafe. Equilin is considerably more powerful and detrimental than the 16-hydroxyestrone. So you can see how we can get some misinformation from the study for women that use this very strong substance and therefore had these increased incidences of stroke and cancer. So it's a little misleading. It's a very valuable study, but if with so many of these studies, you dig in a little deeper, you find out, oh, well, we need to flesh this out a little bit more. And hopefully what I said gets to the bottom line of it, which is that you could, in hindsight, have expected to see this increased risk given what they were using. And with bioidentical estrogens, and we typically use 80% estriol, which is considered a good estrogen, one that is at worst neutral, and at best we figure it's anti-carcinogenic, and estradiol 20%, which we figure is pretty close to neutral. And if anything, it's negative not because of estradiol itself, but because of its ability to be converted into estrone, the 16-hydroxyestrone. So the answer to the question, let's get to the bottom line here, is that there really isn't an increased risk when bioidenticals are used. We haven't done a study like the Women's Health Initiative to prove that, but anecdotally, as we say, we haven't seen this increase incidence of stroke using the bioidenticals. And I'm specifically speaking to the estrogen family right now, because testosterone, we don't see any of these risks of stroke or cancers in females. So let me get to that in a second, but let's look at it even more prudently, which is what I like to do, because as I said earlier, estradiol could convert to one of these bad estrogens, whether you're on hormone replacement or not. So one of the things I like to recommend to all women is to eat your cruciferous vegetables, your broccolis, your cauliflowers, your Brussels sprouts, mustard greens, because they contain an ingredient, diindolylmethane or indole-3-carbinol. They're metabolites of one another. Don't need to know these. They're known in the drugstore as, or the health food store as DIM or I3C. But they prevent the conversion from the good estrogens, we'll call them, to the bad estrogens. That's all you need to know. And either with a diet full of these vegetables or the supplements or both, we can decrease considerably our risk. And you can use a 2,16-alpha-hydroxyestrone test to measure it, or you can actually just look at your estrones and see if you've reduced that family of estrogens down as low as you can. And I think you'd be considered in good stead, meaning you've strongly reduced your risk of stroke or estrogen-sensitive cancers. When it comes to the other complaints of getting fat around the midsection no matter what you're doing and not having energy, that's where testosterone comes in. And there's no risk of stroke or cancers with that. Now, to be technically correct, because estrogen can be made, and often is made, from testosterone, you could go back down the same pathway I just described and say, well, to err on the side of caution, let's use those things that I just described to prevent that conversion, because again, testosterone can convert to estrogen, and those good estrogens can convert to the bad. So let's do the cruciferous vegetables and/or the supplements that contain the active ingredients we want. Either way, but testosterone in and of itself will not increase directly your risk of stroke or cancer, and can improve your life considerably. The same way we've talked about for, it's been years we've been doing these videos.
Yeah.
for men as it can for women. So I wholeheartedly recommend that. And she doesn't give her name, but
how old was she? Did she?
47 years old.
Okay,
so
okay.
This is a no-brainer typically, because, like I said, by definition, the hormones have dropped off. These hormones we're talking about probably since age 35 if you're under an inordinate amount of stress. And as an athlete, unfortunately, that typically means you're stressing your body more than the average person. In this day and age, I wouldn't call it overtraining, but maybe overdoing a little bit, the exercise to the rest or whatever. But it might have happened earlier, is my point. So at age 30, this downward trend started to occur. It'd be worth going to a doctor, is what I'm getting at, to have the hormones evaluated. Most importantly, the symptoms are there, but let's see if it can be tied to the decrease in hormones, and give it a whirl. I wholeheartedly recommend that yes, she look into her hormones and see if that's the reason for the decline in performance and body composition.
Well, I'm sure it's going to please a lot of women to hear what you just said. Oh. So yeah, all right, thanks, Doc. All right, so I think this next one's actually a feedback from a viewer, which you always wanted to hear. You know, you always say, "Oh, I wish we get some feedback." So it's more of a comment than it is a question, but I'll let you take a crack at it. Yeah.
It's a male who says, bit about my wife. She's 53 years old and has had a hysterectomy at age 34. I've been giving my wife roughly 25 milligrams a week. I took 200 milligrams per 1 ml of cypionate, testosterone cypionate, and mixed 7 cc's of cottonseed oil, and ran oil through a sterile syringe filter. Years ago, she was given Test tablets, which was around 12.5 milligrams of test a week, and I forgot how much estrogen. Anyone can look that up. I don't remember off the top of my head either, but Test has a standard dose of both testosterone and estradiol, actually. I was doing the shots every 2 weeks to get her that 25 milligrams a week, but she feels much better when I give her the weekly shots. Now there are times she gets away from the shots for a few months and she feels just like bleep, always tired, dragging, bleep, and no sex drive. Goes to show, ladies, it works. Thanks for the real post. Okay, great, thank you. This is just feedback.
Mm-hmm.
But I'm not sure if I'm making out exactly what her dose is, but if it's 25 milligrams a week of testosterone, that tends to work very, very well.
Okay.
Males, typically we start off with 200 milligrams a week, and females work well with 10% of that, so you can see how it's pretty close. And of course, everyone's different in terms of the way they metabolize. It's just starting dose. So 25 milligrams a week of testosterone cypionate, which has a 8-day half-life, sounds like a good dose. So it makes sense if that is indeed working. And gosh, I don't know where this person's from, but boy, what a loving husband, right? Going through this process of
he's doing it for himself.
Yeah.
Don't worry.
but one thing this is actually a good idea in the sense that to get a precise dose, it's hard to use 200 milligram per ml testosterone cypionate because you'd have to use 1/10 of an ml, and that's very difficult to measure unless you're using a very narrow, small bore syringe, and can pull that out accurately. So he's done a lot of work.
So he's diluting it, make it bigger, and just
right. So you can be more precise with it, which will end up being more accurate.
Yeah.
And that's a good idea in that sense, anyway. And doing it once a week obviously is a proper dose in terms of every 2, because you'd be going on a roller coaster ride otherwise. And I would expect her to feel a lot better. When by the way, when we talk about a hysterectomy, and I don't mean to give people too much information, but a lot of people misuse the term to describe taking out the uterus, which is what a hysterectomy is, as well as the ovaries. That happens a lot, okay, and they call that a full hysterectomy, which is a misnomer. A full hysterectomy just means you took out the entire uterus as opposed to partial, which does happen sometimes, actually. But the term is misused to describe taking out both the uterus and the ovaries. Taking out the ovaries is kind of a funny term, oophorectomy. But I guess the point I'm getting at is that at 34, taking out the uterus only wouldn't necessarily put her in a situation where her hormones were affected, although I just got through saying in a prior question that, by definition, this occurs, this drop in hormones around age 35. So she might have been there anyway. But my point is that just taking out the uterus, a hysterectomy, a full hysterectomy, taking out the entire uterus, doesn't necessarily mean we're going to put someone into what we would call iatrogenically induced or medically induced menopause. You have to take the ovaries out for that to happen. But again, particularly since she's 53 years old now, that makes sense. And she's short on testosterone. This is a great way to replace it. And kudos to this gentleman for doing whatever it takes, apparently. I guess there are no doctors in the area or ability to do it. But yeah.
And thanks for the feedback.
Congratulations.
Yeah.
So next question asks, does HCG, human chorionic gonadotropin, increase testosterone permanently? And if not, how long do we need to do it? Good question. So unfortunately with TRT, testosterone replacement therapy, there is no fixing the situation typically, unless we're dealing with something called a pituitary microadenoma, which is a fancy way of saying there's a little tumor on the pituitary gland, the master gland of the human body, that affects the signal from that gland to the gonads, either the testes or the ovaries in a female, to produce testosterone. Okay, that is relatively rare. So the point being that you can cure low testosterone or testosterone deficiency, hypogonadism, by removing that small tumor from the pituitary. But otherwise, when we use HCG, we're addressing what we would refer to as secondary hypogonadism, which is that failure of the pituitary to send a signal, typically for another reason. Although, look, there's plenty of people that say, okay, well, I see that there's a little tumor on my pituitary, which, by the way, is typically also non-carcinogenic. It's just a benign growth that affects the way everything works. But they say, oh, you're not doing a surgery on me. So we would use HCG in a male to override the system, if you will, and get the testes to produce, specifically the Leydig cells of the testes, to produce more testosterone. HCG is what we call a homolog because it so closely resembles luteinizing hormone, this signal from the pituitary to the testicles, even more so than what we refer to as an analog. There's actually a receptor in the brain specifically called LHCG, L-luteinizing hormone, human chorionic gonadotropin, so they combine the two. Anyway, I'm sorry I'm giving you way too much information than we need. To answer the question, get back on point, does HCG increase testosterone permanently? The answer is no. You are simply filling in where the body is not producing this luteinizing hormone, so you use this homolog to do so, and it will only do its job for, I think the half-life of HCG is somewhere around a day and a half, so that you might get some effect if a patient is young enough to what I call reset the boards. If for some reason we call it the hypothalamic pituitary adrenal axis has been taken offline by some chemical or traumatic incident, and this resets everything to start doing what it was supposed to be doing naturally before. But that's, again, typically a rarity. In general, if someone is at that point where HCG is being used to increase testosterone production, if you pull HCG, it will stop producing. Okay, it's replacing something that needs to be replaced further up the chain. Instead of replacing testosterone directly, you're replacing a signal to testosterone. Now, again, another side note here is that only works for so long anyway. At some point, we move to something called primary hypogonadism, where the gonads say, we're done, dude. You can send us as many signals as you want, but in the case of the testicles, they're saying, sayonara, you can bug us all you want, but we're only going to produce X amount of testosterone. It's not going to be sufficient. And that usually happens, in my experience, in the 30s, unfortunately, such that even when we use HCG, and let's say a patient starts at age 32, he comes in, he opts for the treatment secondary hypogonadism using HCG, and it might work, meaning the symptoms are resolved for a year or two, actually max, with one patient in my history that I've seen an exception to that rule. But the numbers will still be fairly good too, the testosterone numbers, and yet the patient will say, well, I see what you're seeing, same as you, doc, but I don't feel good anymore. I have the same symptoms again. So anyway, the testosterone will not continue to be produced without that stimulation from HCG or some other method. So the question, how long do we need to do it, is dependent upon how long you want to increase your endogenous production, your natural production, and for how long you get the resolution of symptoms, presumably. Now, some people use HCG to stimulate fertility because you need some intratesticular testosterone right there in the testicles to initiate the process within the Sartori cells, the ones that produce the sperm. So that to that end, well, as soon as you get fertile, and presumably the end result being as soon as you conceive, then you can stop the HCG, right? Because you've accomplished your goal. But maybe I'm answering more than I need to.
Do you have any of your patients that are doing it all the time, like continuously, or?
If someone is young enough, it makes sense for a lot of people to use HCG because you're promoting your endogenous production, but that goes into a whole other area of discussion about, well, I'm still having to do something on a regular basis, which certainly isn't natural. There's nothing natural about injecting yourself with HCG versus testosterone replacement. But because it's initiating your own endogenous production, people tend to feel more comfortable with that, and you're not adversely affecting your fertility. You're actually increasing your fertility, which I need to warn patients about. Hey, you're going to be even more fertile this way, more than likely, right? But it's still a production in the sense that you have to inject yourself with HCG. You got to inject yourself more often than you would with testosterone typically,
because it's water based.
You have to refrigerate it. You have to mix it oftentimes and then inject it. So it's not like it's easy or anything, but a lot of people cotton to the idea of, hey, I'm still keeping my own production going, even though it's not natural. So you can use that, as I said, usually into your 30s before it loses its efficacy, in my experience.
Okay, good answer. Thanks, Doc.